So I told you before, loop to 1900, things to really change in healthcare. That much. I mean, you basically natural selection. The fit survived, the non-fit didn't survive. Those who ate well, who had nutrition, probably survived better. Whatever. 1900 comes in, it's on the front of your thing. It talks about Teddy Roosevelt. Teddy Roosevelt was really instrumental in the United States for getting us organized, bringing us out of the kind of the dark ages of things, and getting both business and the country in order. So a very organized guy who's in there for about 7 years, or 8 years, 1.5 terms. So Teddy kind of introduced the thought, but nothing really changed until World War II. So we're really focused on the history of modern healthcare, started post-World War II. First real big change was soldiers were coming back, people were starting to get organized. Healthcare was moving from a rural to an urban environment. Populations were moving to more of an urban environment. And so centers of excellence of healthcare were starting to form. The first one I'll mention is, and this happened in most major states and most major areas, the big cities that we see now, Kansas City, St. Louis, Nashville, Atlanta, all those cities started to gain population and also gain some healthcare. But I focus on Dallas because Baylor Hospital in Dallas was the first first hospital that had the fear of their employees. And so what they did is they created the first Blue Cross Blue Shield in the United States was a not-for-profit corporation. Actually, all Blue Crosses until the 90s were all not-for-profit in the United States. Every Blue Cross was organized by state, but they were all not-for-profit. Anyway, their whole purpose was in Baylor's point, was a defensive move to insure them from their own employees. It's to create basically a self-insured plan to where they put some money aside for their employees to get sick. But they soon figured out they couldn't adjudicate claims. They couldn't manage the insurance versus the payout. So they hired a guy named Ross Perot, who's a IBM sales guy. And actually, they did it for a while through IBM. And then they said to Ross, I'm going to buy you one of your machines, and we're going to establish a corporation. And it can be your corporation, in which it was. It was called EDS, and he formed the first company to start to understand reimbursement and financial things within the healthcare system. Prior to that, it had all been kind of not-for-profit. Everybody does the best they can do, whatever. Nobody's keeping score, and all of a sudden now, Blue Cross is keeping score. But instantly, the idea went out with all the employers in the United States. We created, the United States created an employer-based healthcare system, okay? And that means that most employers would join Blue Cross or a form of Blue Cross that was started out there. And so between like the end of World War II and Medicare, 1965, you just saw this plethora of employers wanting to add benefit to their employees and running this through an adjudication company, a financial company, to manage the money, okay? And so 65 comes in, and you have Johnson, who comes in with this, he'd run the Senate for 5 years prior to Kennedy being assassinated, and he had this great vision of the Great Society. However, if you read about Johnson's motives were not altruistic motives. They were votes. He was trying to get votes. He was trying to expand on what Roosevelt had done in the Social Security system. Started in his term in the 40s, and so he had a Great Society, and he created Medicare and Medicaid. A guy named Maury Levy wrote the law. Lawyer from Chicago wrote the laws for Johnson, put it all in place, and it was funded by the government. It was intended to spend healthcare for the very poor and healthcare for the very elderly. And people in those days, 65 was a break point for when you became ill or more ill, and 81 was a second break point. So Medicare was kind of designed around that. CAID was designed around a money thing, how much money you made, how poor you were. So we had a great number of immigrants that were coming in, people coming back from the war had no jobs, had no insurance, and so anyway, so you're taking care. The anticipation was to spend about $1 billion a year in healthcare. They ended up in 68, they spent $7.9 billion. And so that's when they figured out it was becoming out of control financially. There was a concept coming out of the war, by the way, it was part of the Marshall Plan. I don't know if you remember the Marshall Plan. You probably remember the Marshall Plan,
Sure.
Not you were alive, but you remember hearing about it. A part of that was to create these social systems in Europe on the rebuilding of Europe, and one of those was healthcare. And Churchill had this philosophy that if we supply antibiotics to our population, then everybody, and we pay for it as a government, then everybody will be generally well, and it won't cost that much to do that. So that was a concept that was pulled forward in Medicare, really, was to look for a solution that doesn't cost a lot of money. We can give it as a cure or a treatment for the illness or whatever. So Medicare created that, formalized that, but at a much larger level than it had ever really been done worldwide. So you had, in Europe, you had things like the NHS, start in England, NHS, and every other country had a social medicine system. It was all social. You know, there was nobody making any money theoretically. It was all run by the government, all that. Few dollars, as little dollars as they possibly can do. So you come across from 65, which you now inject billions of dollars in the United States healthcare system. You formalize the education process, training of physicians, training of nurses, training of the ancillary therapies, PTOT speech. All of that comes as a part of the Medicare program and the rollout of the Medicare program. Then the oh my God moment happens in the late 60s and says, we can't afford this. So, and it was, I'll tell the story yesterday, but I know people, I met people, worked with people that were, and eventually went to jail because prior to 83, when they started prospective pay, which is the next cut point, it was cost plus. So you filled out a cost report with all your costs if you're a hospital, turned that into the government, they paid you back quarterly. Just had to have enough cash to operate for 3 months. And then they paid back cost plus 2%. So hospital administrators would go out and buy tons of stuff they didn't need in those days, charge it off to Medicare's cost, and get 2%, get rewarded above their cost for doing that. So the government decided, and it was so much a part of the healthcare system, this kind of inappropriateness was so big that they said, we've got to do something about this. So Harvard came up with a system called the DRG system, which is diagnosis-related groups, which prospectively pay for a certain diagnosis. There are 495 DRGs. Today, there are 495 DRGs for hospitals. After 83, you had the RBUs for the docs, you had the outpatient centers doing all this prospective pay. Today, it's a completely prospective pay system in the Medicare world. Actually, prospective pay and fee schedules. If you look at the transition of reimbursement for really anything, is that when you don't know what it's going to cost, you go into cost base. You figure out what costs are. And then you transition to prospective pay, so you say, this is what it should cost. And then the last phase of that, when you really clamp down, is I'm just going to pay you X. So 83 hits, we hit the prospective pay DRGs. Again, a lot of gaming to the system. That's about when I entered the system. I graduated nursing school in 84 and started with the business stuff in 88. Anyway, so from 83 to 2010, there's really not a lot going on in healthcare other than every year they're clamping down a little more. I will tell you that the wringing out of all the cheating, all of the misuse of the not-for-profit system, that was really a focal point. The first OIG for healthcare was a guy named Kusero, and he was put in about 86. So they started really playing by the rules. A guy named Pete Stark, I don't know if you've heard about Stark Laws. Stark Laws.
What year was this?
Stark was in about 86, 87. I met Pete Starr, I knew Pete Starr. He was from San Leandro, California. He represented that. And I worked with actually Kusero on some of this stuff early on about physician ownership of competing. The doc would be the person that ordered the medicine and ordered the service and ordered whatever, and then they owned the service. So they were double dipping. They were being paid to prescribe it, and then they got paid from whatever they prescribed, which they wrung that out of the system. It wasn't until Obamacare, which is the next cut point, 2010, that the criteria for accountability was changed. Okay, there was a lot of things that happened in 2010. Yes, we did cover the uninsured. 4% of the population we did cover. That was the uninsured. And under Obamacare, basically, that 500-page or 1,000-page, 10,000-page thing that nobody wanted to read had a lot of detail in it about the system, not about just the insured or uninsured, but about how you operate the system. So basically, Obamacare switched us from a kind of fee-for-service world, prospective pay world, to a social medicine, a form of social medicine. Once in the late 90s, I helped 5 European countries get into disease management in their social medicine systems. And so you got to observe, I got to observe those. We went into a German-style system.
Did they deviate a lot from Obamacare?
Well, what Obamacare did is said, okay, let me give you a real example and make it easy to understand. At the time of Obamacare, a neuro MRI, a shot of your head, right? Billed out at about 10 grand. Okay, most hospitals build out, or most providers build out at about 10,000. Most private insurances paid $8,500. Okay, so they paid a little less than what they billed out, or they were paid $8,500. Okay, Medicare fee schedule was $2,600. Okay, far less than what was being paid by the private insurance companies. What Obamacare did is it told the private insurance companies like United Healthcare and Humana and people like that, that you can lower your fees now to Medicare level or near medical. They gave them a window. So in essence, after Obamacare, Medicare still paid $26 for a head MRI, and most of your privates paid $3,500.
But the real question was, as Europe's coming on, are they modeling right after the Obamacare, or they're off in another direction?
They're still off in La La Land.
So they disagreed with what this was being offered under Obamacare.
That's right. Obamacare used the theory that we were flush with cash, and this is the other thing you see in our world economy.
You mean the U.S. was flush with cash?
Yeah, or we were beginning to be flush with cash. We went off Nixon. We went off the gold standard, and we went on the perspective of the economy standard. So how valuable your economy was how much money you could print. And we tell the story. I was just working with Catholic Health Services in Miami, had 8 facilities. I would stay at the Marina. Their base was in Fort Lauderdale. So I'd stay at the Marina Hilton. 30 years ago, I'd stayed at the Marina Hilton, looked out on the intercoastal waterway, and there'd be a couple of 200-foot yachts. Last few months ago, I'm looking out the window, and there are hundreds of 200-foot yachts, i.e. cash has just been flushed into our society, into our economy. So, but that's kind of a side point. What happened was, to the system as it became social and its expectation, it also implemented a thing called population health, which means that it's the better good or the greater good. So you start seeing the denial of care by the private insurance companies, the reducing the fee schedules. Oh, and Obamacare guaranteed them 15% profits. So they could lower their fee schedules and remove some of their opportunity to make money, but on the backside, they were guaranteed to make money if they did all these things that Obamacare told them to do. Pull it forward a few years from Obamacare, and they start the Medicare Advantage. Medicare Advantage is what we have today. So if you're a Medicare age person and you buy Medicare Plus, I have traditional Medicare, I'm Medicare age. I have traditional Medicare. I have a 1 to 2% cost of overhead. So Medicare gives, or HCFA, or CMS gives Palmetto, which is in South Carolina. Every time I go to the doctor or hospital, whatever, there's a 2% charge for handling that claim. Okay, if you're Medicare Plus or you're in one of the Medicare Advantage plans, there's a 15%. What happens to that 1 to 2% versus 15% is the money coming out of CMS is the same, so you're getting 15% less service from the Medicare Plus or from the private insurance. But in way, unless you know what you're doing to navigate, the government says we're going to find, under Bush did this to us, is that he created Part D Medicare, which pays for meds. If you don't buy a Part D plan to help the government work that Part D thing, they fine you. Well, if you go to most of your insurance companies, pick up the phone and say, I want to buy a Part D plan, they won't sell you a Part D plan. They'll sell you Advantage, the whole plan, where they're cutting it 15%. There are companies like Medishare, it's a Christian company, they don't do that. Some of the other shared companies like Samaritan, they don't do that. But most of your privates will actually push you away unless you buy their whole plan. What you see on TV right now with Medicare Advantage is Joe Namath up there saying, well, we're going to buy $2,000 worth of groceries for you. If you sign up for this Medicare plan, we're going to buy $2,000 this year worth of groceries. And the people that are very poor do that. By the way, Advantage works well unless you're sick. Okay, if you get sick, then you need all those services. But if you're not so sick, then maybe you do Advantage and have a little extra cash in your pocket or whatever for a while. I'm not making a moral judgment, I'm saying it's the impact of what you, as a consequence of population health, you saw this reason of today's conversation was to lead you through this perspective of, we went from a kind of a, you're the patient of the doctor, you're the patient of the hospital, you're the patient of the system, to the system is the patient. And so under Obamacare. And so what you see is that you dumb down the system. Under population health, you get rid of all your primary care providers. Look around you. There are no doctors left, hardly, in the primary care space. And the ones that are left are getting paid not very much money. Dr. Field was in here.
Will Mills.
The fee schedules are terrible. I'm a nurse practitioner here. As a nurse practitioner, I get paid 80% of what he has, much more education I have, and I get paid 80% of what he gets paid. So there's been a dumbing down, and so through that dumbing down, population health says you're taking the practice of medicine to a technology of medicine. So when you go to the doctor today, when you go to the doctor or wherever you go to the doctor, if it's in a big system, the system, prior to your appointment, the system prints out, this is who you are, prints you out. The provider looks at it and says, okay, but it also will probably tell the provider what to diagnose, even without seeing you, what to diagnose and how to treat it. Protocol. So it's a protocol medicine based on your 50 years old, you have blue eyes, you have your mom died of this, your dad died of that,
it's an algorithm.
Dog has fleas, there's a whole algorithm, right, of things that goes on that says this is what likely his or her chief complaint when he hits the door will be. By the way, it's all driven off chief complaint too, because if you have other things like diabetes and a sore throat or cancer and a whatever, many times your primary care will not be interested in a secondary, like your cancer or your diabetes, as much as they're interested in your sore throat. They're going to treat you for the sore throat. They're not going to deal with the other things generally. Now, over time they deal with it. I myself have gone through this and have a very good primary care guy, just retired from Mayo. His name was Dr. Stan. And he's my age, he's an old guy in practice, and he did all those things, but he did them outside of the system. The other things you see, you don't see Dr. Stan. Dr. Stan was internal medicine, Cleveland Clinic, Mayo trained, all that kind of stuff. What you see now is a nurse practitioner or a PA. You may see a doctor in the building because under the law of Florida, As a practitioner, I cannot independently practice. I have to have a physician somewhere in my world. PAs, under the law, are supposed to have a physician readily available. PAs have less education than nurses in that regard. But in Maine, I can just go out and hang out where I have a house in Maine. I can go hang a shingle out, and I'm a practitioner. And as long as I get my Medicare provider number and my insurance provider numbers, I can bill 80% of the 80 to 85% of the Medicare allowable or the insurance company allowable. Anyway, the point is that we've now, under the population, now dumbed it down a bit. So these protocols cranked along in the 2010 to 2020 time frame, and they were maturing, getting more and more, taking hold of, it's like boiling the frog. The frog's in the water's being heated up a little bit, and it's more and more being implemented, these protocols and this population health strategy of medicine. And so what happened in 2020, you had COVID. COVID drove, under legitimate legal terms, Anthony Fauci could stand up under public health law and declare a public health emergency, which he did, and mandate that you do certain things, like wear a mask or take a vaccine or whatever. Whether you apply or complied with that mandate, that was your business. But under the law, he had the right to do that, and he did that. He said nobody could go to church, but you could go to the strip joint, but you couldn't go to the church, right? He mandated you go to the liquor store or buy your marijuana, like in Maine, they can buy marijuana on every corner. But you couldn't go to the grocery in some cases. Or
peaceful protest.
Yeah. So anyway, so COVID put the hammer down, so to speak, and made these protocols very, very, very strict. Okay, and so they're boiling the frog. The frog was boiling by that time, and whatever happens to the boiling frog, right? Come to Biden. Biden, while Obamacare took away a lot of the accountability for both the insurance companies, physicians, hospitals. By the way, hospitals are all, they have a thing called JCAHO, Joint Commission of, I don't know, something, JCHO. And it's if I'm an administrator of a hospital, I pay maybe $1 million. If I'm Baptist Hospital, I pay them $1 million to JCAHO. I pay them. They come in and review my hospital, and if they find anything really bad, they're not going to say it because I'm paying the bill. So they're going to write a big plan and say, well, you've got 90 days to fix this. But when 90 days is up and you hadn't fixed it, they'll write you another one, 90 more days. So, and eventually big facilities like a Baptist or a Mayo or a University of Florida, they comply because they want to be able to have 5 stars on the Google system or, have all the credentials that they put out on the thing. It's not to say JCAHO doesn't work, but it is a voluntary compliance, and it's only as good as the ethics and the morality of the system itself.
Do they do that in place of a standard government oversight?
The only time the government I was operating a hospital in Maine on the Canadian border, small hospital, 25 bed, we had 60 beds total, but we were reviewed by the state of Maine. We were instead of JCAHO, because theoretically we couldn't afford to pay JCAHO. So they brought the state in and did our reviews. But that's the only time. State of Florida, I'd say they don't even have reviewers anymore. People that come in and review. Even the smallest home health agencies have to have CHAP. It's a JCAHO type product. The one in Miami in the Catholic Health Services was a huge, 1,000, 1,500 patients on service at all times, and it was all voluntary. So, but when the government says we don't care anymore about fraud and abuse, for example, we don't care about or compliance with fraud and abuse. Only the most egregious stuff came out in the Biden administration. Most of that stuff was dumbed down to where it was just glazed over, i.e. you saw insurance companies The guy got shot in the back. He was shot in the back theoretically because he was denying claims. His company was denying claims. You see a rampant institution of that. You institutionalize denying care. Okay. One of the things that was the impact of Obamacare also was the accountability for the payer. United, I'll pick on them. All through my career, I've dealt with United since the 80s. They were in the HMO business, right? They were always terrible pay. You know, if Medicare, Medicaid was 60-day DSO, you know, time they're going to pay the bill, United Healthcare was 120, 150 days, you know, and you had to bill them 2 or 3 times, or they'd take a claim worth $10,000 and they would pay you 3 or 2 and say the rest of it we're not going to pay for you, so you'd have to keep billing until you got the rest of the money back from them. And they were notorious for that. They have there's a thing that's happened in our healthcare system is that in the days I was running these public companies, you had everything you did was to make profit, you know, profit, but you didn't cross the line where I call it pathologic profit, where you institutionalize denying care. You basically plan on denying care. You basically plan on, under these algorithms for population health, if you show up with a certain disease state, I use myself as a real example. I was coming out, I just left Saudi. I wanted to go back and do some clinical work for a little bit, so I took a job as a bone marrow transplant. I was certified in transplant at CTCA in Atlanta, Cancer Treatment Centers of Atlanta, of America in Atlanta. And I jumped up in the truck and I scratched my knee. And I was on my feet a lot more than I normally was. I was scratching my knee, but it was a scratch, you know, but superficial. And so a couple of days after, I start to see my knee swells. Okay, I'm starting to get an infection. So I said, okay, and I'm standing up a lot, and so I thought, okay, I'll put some stuff on it. But in a couple more days, I got to where I couldn't stand on that leg. So I said, I've got to go to the doctor. So I go to a local doctor in the box in Noonan, Georgia, and they give me a certain antibiotic. Well, that's in protocol. That was in their protocol, up to date. Their little tool they use said they should give me penicillin, and they gave me penicillin. 2 more days go by, and I'm septic. My heart rate's up, my blood pressure's up, I'm having symptoms of sepsis. So I reach in my bag and I pick out a Levaquin, which is a very strong antibiotic, and it takes 7 days. Levaquin, and I'm cured. But if I had gone through the system, gone back to the doc in the box, we'd have gone to 2 more visits before, and probably a hospitalization before I got to the point that I was getting Levaquin. So that's.
Isn't that process more expensive?
It is, but some people will just die.
Okay, so
some people
they're betting
will,
on the statistics that some people are going to not fight it and they're going to die, just like deny the claim,
right,
and deny the claim, and if they keep fighting, okay, deny the claim,
right,
all right, fine, they're going to sue us, all right, approve it at this level here, and
right.
and then maybe they won't fight that anymore. It's like fight.
Well, and what they'll do is the insurance company will say, well, that's in the literature. I'm supposed to give penicillin, and they'll pull out 15 articles that say that's what you give for a scratch infection. Okay, but it didn't work, you know. So they will win on the appeal,
Yeah.
and you'll end up paying privately or doing something, or you escalate up, you get sicker, you know, and they cut your leg off or something. Then, yeah, it costs them more. But how many people? 1 out of 10 gets there, right? The rest of them either get something else, they get better, whatever, or they die. Okay. That's how cold the system is. That's how cold population health is. It's the better good of the population rather than better good of you as an individual. I say this not to doom and gloom you, it's just the reality of the healthcare system we currently are in. There are some bright spots, and we'll talk about the future, because I think part of the future is that you have to have advocacy to be able to survive this, okay? There's a thing called concierge medicine that's a concept that's been out there for years, where you have a doctor that you pay, it's usually a real doctor, could be a nurse practitioner or a PA, but they know medicine, and you pay them a $1,500, $2,000 fee in January, and they become your advocate all year long. That way, when they start this craziness in population health, you have somebody going, what if, why are you doing this? You know, that doesn't sound right. This lab value is not right, whatever. So you have an advocate, not just like a family member advocate, but you have somebody knowing what's going on, advocate. That's probably your best place currently. Future will say what Trump said the other day. It's fascinating to me that he's talking about this, because he's up there with the guy, Larry, that started Oracle, the guy, the CEO of Sunbank. He's doing this Trump conference right in front of the White House, talking about AI and how it's going to impact healthcare. They specifically picked healthcare, probably because it touches everybody. The possibility of having AI wring out this fraud and abuse type mindset of this population health is possible. You can, the genetic tools actually exist today. I was doing it when I was in the Middle East. I can swab the inside of your mouth. I can tell you what you're most likely to die of, which cancer you're most likely to die of. Public health school, went to public health school for a while. So the first day of school, they said, if you don't die, if anybody in this room, you don't die first of something else, you will die of cancer. Case in point, my mother died last year. She was 100 years old. She'd been healthy all her life. She died of pancreas cancer. She was sick for about 6 months and died. So the main mortality elements, let's call them elements, because cancer is just one. You have markers for all kinds of stuff floating around in your blood. And so once you identify these genetic markers, then you test for them continually. So if you're a colon cancer high risk, or you're a lung cancer high risk, or whatever, and you don't smoke, you don't do things that are bad for your body, then you periodically, once every 5 years, draw some markers for those tumors. Once you identify, then you treat with. It's a good thing about modern medicine is we haven't created a new chemo in years, since 2000-ish time frame. The new drugs are all NABs. They end in NAB. The drug name ends in the NAB or a TIB or whatever. And these drugs are meant to gin your immune system to fight a specific disease. Okay. So if you have prostate cancer, one of the gentlemen yesterday had prostate cancer, he's being treated with a NAB that's very specific to prostate cancer for his immune system to fight that prostate cancer. Those are very successful. The earlier you intervene with a NAB, the better off you are. So if you pick up before the tumor exists, before you pick up a tumor marker that says that you're likely to have that tumor or that cancer, and I picked up a marker early on and I give you that NAB, I may only give you a few doses and wipe it out. You have cancer, by the way, floating. You have most of your diseases are floating in your blood or your bone marrow right now. It's just your immune system is handling that. The healthier your immune system is currently, the more you're able to fight off those chronic illnesses.
Those NABs those are all monoclonal antibody type
Yes.
treatments that are designed.
They start with T cells. When I would do a bone marrow transplant, the patient would come in, I'd pull off T cells. Okay, so I'd give them back their whites and their reds and their plasma, but I'd keep their Ts. I'd send their Ts off to Baylor, in our case, and they would treat the Ts. Because this was called an autologous system, where I'm taking the patient's blood and I'm giving it back, or their Ts, and giving it back to them. So I'm treating the T cells that have the cancer in it with this, and then I'm killing all their bone marrow with some chemotherapy the day I give them the infusion. And then I go right back, and then I just pray. I'm sitting in the room with them for 23 days because their immune system doesn't exist for those days until they build up the immune system. It's fascinating because we had one time I was in the process of giving the cells. They come frozen. And there's a water bath special thing. You bathe these bags of T cells in. They dropped one on the floor. Well, once you kill somebody's bone marrow, they'll die if you don't give it back to them. If you don't give something back to them quickly. So they dropped it on the floor, everybody scraping up all these cells. We still gave them to the patient. But then we treated them for every known disease known to mankind for that length of stay, and they were fine. They went through the entire process and they were fine. But you have to, that's a all or none prospect thing. We would give NABs. NABs can be dangerous too. I was getting Gazyva and Yondelis when I wasn't busy doing the transplants, and those two drugs are for sarcomas. Sarcomas are most cancer in your body is hypervascular. It's lots of blood flowing to it. These sarcomas are hypovascular, and this Yondelis and Gazyva were treatments for that, and I'd say 80% of the people that I infused died because they reacted to the Yondelis or the Gazyva. They came in, not while I was with them, but within 2 weeks they were coming back with what's called ARDS, acute respiratory distress syndrome, and they would die of respiratory distress syndrome. So it's it's good, but it has to be. It's not a magic bullet. You have to be very careful as they're doing. That's the reason if you ever have cancer.
Is that why they had some of the reactions to remdesivir?
Yeah.
Because you go into acute respiratory failure.
Yeah.
And
Oh yeah, remdesivir is special by itself, and you go into respiratory.
That's the kind of reaction they had.
Yeah. They had it with ARDS. It's called ARDS. You put them on a vent, it's just almost like COVID. They're in such an immune response, like a shower of immune things are happening in their body that they can't recover from it. That was what was happening in COVID. You would have that moment of time, that shower would happen, and then put them on a vent, and then they couldn't get them off the vent. I went to a place in El Paso, Texas, where they had a couple of thousand ventilator patients during COVID. They were laying like this in a tent in El Paso, Texas, outside. There were so many of them they couldn't treat them. But again, let's get back into genetics. We talked about this yesterday. Your genetic makeup makes you more vulnerable to certain diseases. Caucasians had less trouble with COVID than Hispanics, especially. Black was also. Go back to Johnson. Johnson's political thing. You had Part A and Part B of Medicare. And you had ESRD, renal dialysis. 99% of people with renal dialysis in 1965 were black. And so he carved a special program just for black population to retain that vote. Okay, today, still pretty high incidence because of a genetic phenomena within the black population is that you have renal, the blood supply to the renal, to the kidneys, genetically is narrowed. And so when you build up a plaque like you would build up in your heart, that plaque builds up in that renal artery and cuts off the blood supply, and so they become less efficient, and then finally they perish. So again, it's just a part of their genetic makeup. Hispanics, diabetes. I've had hospitals in El Paso and Harlingen and several places on the border, and every one of them had diabetic clinics because no matter what they did, what they ate, what they did for a large part of their population will become diabetic because of a genetic predisposition. We don't talk about that much in healthcare because I'll give you another real example. When I was at Saudi Arabia, I was working with King Saud University when I was Boston Scientific. We were working with the doctors on genetics for their population, and 60% of the males in Saudi Arabia, Saudi is a very homogeneous, nobody moves in or out of Saudi Arabia, so it's a very homogeneous population. 60% of their population has adult onset diabetes. Now, why is that? Because historically they didn't. They changed their diet. They had this predisposition, and now they were eating whatever they were eating when they were nomads in the land, and now they started eating Western diets, which were high carbohydrate diets, and they started to develop this diabetes. The latest stuff on the adult onset diabetes is that it's actually a bacterial infection that it caused in the pancreas. That's the latest stuff I was reading this week. So we're learning more and more. Maybe our diet promotes that kind of bacteria within the pancreas. We have, in today's healthcare, if you look at a public health standpoint, huge liver disease because of we eat so many things, and we'll go through that here. We have approved 10,000 additives to our food system, to 10,000 plus. Europe has, 300-400. People life expectancy is 10 years higher in Europe than it is in the United States. Their morbidity, people suffering from liver disease, is less than half of the United States. So whatever we're doing through these dietary supplements and dietary, not supplements, but dietary additives, also GMOs play a part in that. Most of your food in the United States, everything we eat today, is GMO. It's genetically modified seeds. There's a great reason for that. Grew up on a farm. If you get higher yields, you have less insecticides, less fertilizer, because I used a certain seed that, by the way, that I couldn't buy anything but that seed. Why wouldn't I do that? Because I'm going to make more money if I'm a farmer or whatever. So you see this whole GMO, which is sometimes not bad, sometimes it's good, but we don't know. Something's causing liver disease. Something's causing chronic illness to increase in the United States. Sure, we can try to do what John's doing, I'm trying to do, everybody probably in this room is trying to do. 99% of the people out there aren't trying to do anything else, right? But we still are forced back to the eating GMOs stuff.
So
and
farmers get subsidy from the federal government.
To also grow, yeah.
Yeah.
You had started to say, if you get cancer, and you were gonna tell us something
Oh,
to do.
if you
and then
get
a
cancer,
chance-
go to a main cancer center, okay? Go to an MD Anderson, go to a Sloan Kettering in New York, go to a Mayo Clinic in Rochester. They're different. The one here in Rochester is different. City of Hope, if you're a child with cancer, or Memphis to St. Jude's, go to a place where they're actively doing research. Research is a kind of a misnomer, okay? Research, like they do at Mayo here, is long ago we did 1, 2, 3, 4 trials, okay? The levels of trials. And so when you get to 5, the 5th level of trials, you're just giving it to people, and docs are recording the result. Okay, that's the research they're doing out there. The people doing the basic research is all happening, in my opinion. The one I did one called SpectraPath in 2016 and 17. SpectraPath was a laser that would view head and neck cancer. When you had head and neck cancer, you could either go in through a laparoscope, or you could cut the neck open, and you could view the cancer cell down to the cellular level. So when the problem's in the head and neck, you can't separate the nerve or the blood supply. Same thing with pancreas cancer. If you get pancreas cancer, it's right at the head of the pancreas where the blood supply is. It's hard to separate for the surgeon the tumor from the blood supply or the nerve, and you kill the patient by doing that. So this thing, we brought it into Europe, did all our clinicals in Milan and Holland, and it cost us $3 to $5 million to do our clinicals there. In the United States, to bring that product, we never brought it to the United States. It would have been $30 to $50 million to bring it to market. It's that much more expensive in the United States to bring it. So, so most of your first level of trials for either medical device or new drugs is going to be happening overseas someplace, and then coming onshore to the United States. After you have also money. I had when we were doing SpectraPath, I had a relationship in Saudi Arabia with a drug company, and they guaranteed to buy $25 million worth of those before I even had it authorized. So but it helped me because I had money coming in for that product that I can then promote that product back into Boston Sci and
the hospitals, that whole idea of nonprofit.
Oh yeah. Non-profit. It's from the very onset, and they go back in time. I skipped over a little bit of that. when you came out of the nonprofit, like 1945 to 1950, you had a little thing called Hill-Burton. It was a law passed by the federal government to incentivize communities to build hospitals, right? So these non-for-profit, these cities, counties, whatever, went after the Hill-Burton. They raised, bond money for $1 million, and for every $1 million they raised, the federal government gave them $3 million under Hill-Burton, maybe sometimes $2 million. And so they built their local community hospital, and they continued to be non-for-profit, and so they cranked along in the cost-plus world, being very, very inefficiently operating their thing, until about '68. Tommy Frisk, one of the guys I worked for at one time, he was retired or near retirement when I was working with him. He started HCA. HCA said, I'll go out to the market and get my $1 million instead of my local community, but I'll apply for Hill-Burton and I'll get my $2 to $3 million in addition to my investor money. And so for every dollar, it's $3. And that's how Tommy became rich. He went all over the Southeast and really all over the United States. Humana did the same thing, by the way, out of Louisville. They were in the nursing home business, and they went into the hospital business in that Hill-Burton time. So, but what happened was, when I was working with Dr. Frisk, he would tell me, he would say, look, I am operating like a not-for-profit, and I'm making 25% dropping to the bottom line. He said, Plano Medical Center was one of my primary things I was doing. And Plano Medical Center at that time was $170 million a year reimbursed operation. So you're talking 25% of that much money out of one hospital dropping the bottom line. Dr. Frisk's point was all the non-for-profits are getting paid the same amount of money that I'm getting paid. What are they doing with that money? So what you had is you had a built-in inefficiency. It exists today, is that Baptists, maybe Mayo, I don't know what Mayo is or not, they are not-for-profit, 401c3, 501, whatever, corporations, and they try hard to spend their profits on buildings and paying their administrator. Their administrator in a not-for-profit hospital will make $1 million a year, where HCA is paying their guy $200,000 a year. I'm not trying to say the for-profits are better than the non-for-profits. It's just the for-profits are taking that margin and paying their investors. The non-for-profits are taking that margin and doing something with it. That's creating an inefficiency. Case in point, I was doing the thing. I left Frisk. I was gone. I ran a public company for a while. Came back, and then I started working with Rick Scott. We were rolling up Columbia Hospital Corporation. We bought HCA, we bought Humana, we bought Health Trust, we bought all these for-profit hospitals and some non-for-profit, rolled them all together in Columbia Healthcare. And the amount of money was just startling. How much money you could make out of it. That's the reason he bought the not-for-profits. He'd buy them, make them efficient, and just make tons of money out of them. So he fell apart because he was growing too fast, and he got in trouble with some of his hospitals, like in Florida. There were a couple hospitals, CFOs went to jail, and Scott had to leave and go to New York, and then eventually back to Florida. But it was the concept of a non-for-profit business. I was going to tell you about Greenville, Texas. As I was doing the same for Scott, I went to Greenville, Texas, not-for-profit hospital, and I said, okay, if I go to your local community, we were thinking about buying the hospital, and so, but I was trying to help them up their revenue. I said, if you go to the market and I buy Betty Pogue's home health agency that's here in town, put it inside your hospital in a reimbursement standpoint, from a reimbursement standpoint, and operate it as a hospital unit. One, you'll pay for the purchase price in 1 month, because you'll be able to allocate enough overhead down to that home health agency under its current size. And you'll make, I don't know, millions, several $1 million more a year, which then will make your value increase. So I'm in front of the city council. It's a community-based, not-for-profit. And they turned me down because they didn't want to make money. They felt it was threatening that they actually made more money. They were having trouble as it was, getting rid of the money they were making. So, and this was in the 80s.
You have that problem, don't you?
Yeah. So, anyway,
I want that part.
so the not-for-profit world, Frisk played a part in it, but Frisk and them were not in this pathological mode. Pathological mode says, I can make money traditional mode was, I can make money by just being efficient and doing good work, doing good healthcare, whatever, in theory, okay? Pathological says, I can make an extra margin if I deny a claim here or there, if I go through population medicine algorithms for care, if I hire not doctors, I hire PAs and nurse practitioners, make a lot more money. You know, I'd say in my reimbursement, I get paid for the doctor and I supply lower level care. So those are the pathological parts. And so when John was here yesterday, he said, well, why don't we just all the Christian companies get together and try to convince through stock or through ownership.
Ethics and values.
Yeah, try to reinforce that. And I'm saying BlackRock and that group own these hospitals. I mean, own these insurance companies, okay? And if you say to BlackRock, I'm going to lose a little money off of this quarter, off of my top line or bottom line, they'll fire you. They're not going to let you stop doing those practices that are paying money. So, until they absolutely have to. And this is the future. The future is AI has an opportunity with what these guys were talking about with Stargate, which is out in Amarillo, Texas. They're building 10 supercomputer systems with its own power plant and all that will be the AI generator for the United States. On the other side, it could be the God thing, right? Because
We're gonna name it Skynet.
but
I'll be back.
yeah, or you could take all those genetics that do the swabbing of your nose, knowing what your disease states are, keep all that thing in best practice, and distribute. That swabbing in the nose and treatment, all that can be done today, but it can't be universalized until AI. It can't be everywhere. So if you show up in New York at a hospital or a doctor, or you show up in Los Angeles or San Diego, you're viewing the same set of information. That's what AI does to you, and then it universalizes the protocol. Now, if you're on the back side, or the dark side of that, you can also create those protocols to your advantage, to whoever's advantage. Theoretically, the government would want help. One of the things you see in pharma right now is that pharmaceuticals, starting back with the antibiotics in post-World War II, the drug invention system quickly figured out that we don't want to cure disease, we want to treat disease. Okay, so we give you enough chemo or enough NAB that keeps the, prostate cancer or the bone marrow. I would give a drug called Revlimid. It's a PO drug. You give rituximab when they're in acute phase. So that's lymphoma. I give you an infusion for a couple of hours. I give you a couple other chemo drugs with that, and within 24 hours, your lymphoma is not there. You just don't see it anywhere in your body. Magic cure. However, if you don't take the PO continually, $12,000 a month, by the way, keep taking the $12,000 a month, you're going to have a recurrence within a year. If you're over 55 years old, your likelihood of having a recurrence in a year is like 80% or something. So now you're hooked. You get the fix, and then you get the ongoing treatment plan. Currently, the pharma companies and the society, the Cancer Society and all that, are paying some of the bill for these NABs for people. But my wife works in cancer at Mayo in the prostate and GU and also melanoma. And she said January 1st, there were a lot of patients that went from paying $200 a month for their NAB, their treatment NAB on a monthly basis, to $2,000 a month, because some of these plans fell off their reimbursement, or fell off their providing money for them. So,
Why don't we open it for questions that people have, or to